Good afternoon. My name is Steve Sell. I'm the CEO of Agilon Health. And today with Dr. Bill Wulf and Dr. Kevin Spencer, I'm really pleased to talk to you about the importance of preserving access to independent primary care for Medicare beneficiaries through global risk. I get the opportunity to work with Bill and Kevin every day in a unique partnership. We're going to get a chance to talk to you about that. Before I dive in on some slides, I wanted to have Bill and Kevin give a brief introduction about themselves.
Thanks,
Bill?
Steve. I'll go first. I'm Bill Wulf. I'm a physician and internist by training. I am the CEO of Central Ohio Primary Care Physicians, the founding partner of Agilon Health with Agilon, and I am also a board member of Agilon Health. And I'm really pleased to be here with you today and share the importance of independent primary care.
Thanks, Bill. And I'm Dr. Kevin Spencer. I'm a family medicine doctor by training and the CEO of a 60-provider primary care group in Austin, Texas. Like Bill, I partnered with Agilon Health. We were the second market in Austin, Texas to partner with Agilon Health, and really looking forward to sharing with you what this global risk model has done. Specifically in Austin, you'll hear about the access to care for Medicare beneficiaries, which is so important. So thanks for having us.
All right. Well, I think we can go to the next slide. And the theme that I really want to hit throughout all this is that independent primary care doctors play a crucial role in transforming healthcare in the United States. They are the most precious asset that we've got in the healthcare system, and really growing that access is going to be important, particularly as the nation ages. We have 10,000 people a day turning age 65, pressuring the Medicare program. The demand for primary care is outpacing the supply that we've got today. And primary care doctors are burning out. And so we at Agilon have constructed an organization built around this idea of partnering with existing primary care groups like the ones that Bill and Kevin are a part of to really transform healthcare at the local level. And so it's not just more primary care, it's more independent primary care. As the middle of this slide shows you, healthcare costs increase substantially when physicians are employed by health systems. And just under half of primary care physicians today are independent. And our mission is really to sustain and grow the amount of primary care in each of the communities that we serve. If you go to the next slide, this shows you a view of how we are working today in 17 communities and 8 states with 1,600 plus primary care physicians and 21 different payers, both the Innovation Center through direct contracting, as well as health plans through Medicare Advantage. Our partners are leaders in their community. They're mission-oriented. They are physician-owned. They've been there for decades. They're incredibly well-known and respected. And our partnership is focused on working with them to truly drive improvements in cost, quality, and experience. In the 8 states in which we're operating today with those 17 partners, we will be working with our partners to collectively recruit more than 150 additional primary care doctors in the next 12 months. So these communities are no longer seeing a decline in primary care. They're actually seeing an increase. And value-based care is allowing that additional investment in care coordination infrastructure and access. In addition to having more primary care doctors in these communities, we're focusing on increasing the quality of those visits and the number of primary care touch points that senior patients are having, in particular high-risk patients. And what we found is as we double and triple the amount of primary care, we're able to dramatically reduce the amount of emergency room and hospital stays, which is significant from a cost, quality, and experience perspective. As we drive improvements in quality and efficiency, we are able to reduce costs and share in a 50-50 partnership with our physician partners that surplus. That's allowing primary care compensation to as much as triple in these communities, which is not just great for our partners, but it's drawing more people to primary care, and more independent physicians within those communities are choosing to join us. So it's a real virtuous cycle where better cost, quality, and experience is leading to more primary care doctors choosing to join into the model, which is super important. If you go to the next slide. This shows you that Medicare Global Risk is creating financial stability for independent practices. And the global risk is coming to us both through health plans and the Innovation Center through direct contracting. And that's allowing transformation, like from the picture on the left to the picture on the right. On the left is what you see before we partner with these groups in these different communities. They'll have multiple health plans or working with the Innovation Center or an ACO, and each one of those payers has different requirements in terms of reporting, in terms of quality. They have differences in terms of eligibility, in terms of who qualifies for that. And that creates a real fragmentation and dislocation as the front office staff, as the physician needs to understand which payer a patient is coming from and meet those unique needs. That creates a very fragmented patient experience. What we've done at Agilon with our model on the right is created a physician-led single Medicare line of business, regardless of whether you're in direct contracting or you're in Medicare Advantage with, say, Anthem or Aetna. You will have the exact same experience in the office, follow-ups for appointments, quality programs, things like care gap closures. And it's built around this idea of a single brand identity and a consistent experience for the patient and the physician. This allows for much better outcomes, again, in terms of cost savings, and it's really allowing better focus from our physicians. What we've seen is dramatic increases in terms of net promoter scores that we'll share with you at the end of the presentation. It's really driving a significant transformation in each one of these markets.
And Steve, I would just chime in on this. As we developed this structure, we knew this was the structure we were getting into, but we really didn't understand the full benefit of that single experience for the physician. And it's really had a dramatic impact on our physicians because any Medicare Advantage patient, and with DC, any Medicare patient is really coming to the physician in the same way, and the physician can treat them in the same way. So this was a real pleaser for our physicians that we didn't expect.
Yeah, no, great point, Bill. If you go to one last slide, before I pass to Bill to talk about the experience that they've had in Columbus, what I close with this idea is we've really tried with our partners to create a new category. We call it high-value primary care, with the idea that primary care physicians are the most crucial asset we have in every community, and they should be guiding and quarterbacking the overall care, responsible for that total cost, quality, and experience. And we know that today, primary care accounts for 5% of the healthcare spend, but is directing 82% of downstream costs. It has an outsized impact, and every dollar that we invest in primary care could yield up to $13 of downstream cost savings. That's why this idea of the primary care physician as the quarterback can be so impactful. If we go to the next slide, I'll pass to Bill. And Bill, why don't you relate the Columbus case study and what the experience has been there?
Yeah, thanks, Steve. And I guess I would start by saying this is the Columbus case study, but we see this similar experience and similar dynamics and similar efficiency in all of our agilon markets when we deal with independent physicians. And clearly, we believe that independent primary care drives efficiency. And so the data you're seeing on the left side of your screen is Central Ohio Primary Care compared to the Columbus market in Medicare fee-for-service data, so direct contracting data. And you can see that if you're a COPC Medicare patient, we are 20% more efficient in the total cost of care at $885 per member per year, per member per month, versus $1,065 per member per month. And again, we're seeing this in all of our agilon markets. Our concern is, as Steve addressed, is the how many independent primary care physicians there are in a market. And as you can see, COPC is 26% of the primary care in the Columbus market. There's another 9% that remain independent, but a full 65% of physicians are employed by either a system or a payer in this market. We do think that we can move those physicians to higher value at some point, but right now we're seeking independent primary care physicians because of the value that they are already driving. Next slide, please. You've all seen this delivery model on the left side of your screen, and that is we risk stratify patients just like any organization that is in shared savings or in total cost of care risk as we are. Many patients just need good primary care. Patients beyond that need, of course, specialty care. Some require hospitalization, and some will require end of life care. So what are some of the capabilities we've built in this market along with agilon? Well, number one, we've got 5 same-day centers. These same-day centers, 2 are pediatric, 3 are adult. These are our urgent cares, just for our patients. We're not interested in being urgent care for everyone in the community. This is for our patients after hours and weekends. We have a large hospitalist division. When COPC was founded in 1996, one of the reasons we developed the organization was to develop a hospitalist program. And we actually have 100 of our 478 physicians are hospitalists. They take care of our patients in 4 hospitals in town, our 4 busiest hospitals. We also have 3, soon to be 5, skilled nursing facilities that we staff for just our patients. We've got dedicated RNs for post-discharge transition. So these are transition of care nurses who sit at the bedside the day after admission and intermittently through an admission and help the patient during that transition home. That will include setting up a follow-up visit with their primary care physician, a call to the patient post-discharge to see if they have any needs, and those needs may be a nurse, a social worker, and or a physician in the home. And we'll provide all of those with COPC employees if necessary. We have a 24/7 inpatient support center. This support center supports all of our hospitalists in those 4 hospitals, as well as provides advice to our outpatient physicians day and night regarding the need for an admission, whether a direct admission is appropriate, and which hospital that patient may be best served. We have a centralized referral management system that has been rolled out to about 50% of our offices. We're doing that slowly so that we can manage referrals in not just a timely fashion, but then also be sure that our patients are seeing the correct specialist for their condition. As I mentioned, we have home visiting physicians. We have 3.5 FTE physicians, as well as APPs that will see our physicians, whether it be for palliative care, whether a patient is homebound, or whether that patient actually needs an urgent visit today to keep them from being hospitalized. As I mentioned, we do have care management for those patients that require it. Being hospitalized automatically gets you care management. Also, certain conditions get you care management, and that's a nurse that will assist you in your long-term care, be it of chronic disease or an acute disease. And we also have dedicated high-risk patient clinics and an ER diversion program. So we can see high-risk patients today in an outpatient setting rather than the emergency room. if one of our patients gets to one of those 4 busiest emergency rooms in town, we have a nurse at all 4 of those emergency rooms that assists the ER doctor in getting that patient home if it's appropriate. ER physicians, really what they want to know is that patient can and will get follow-up. So that ER intervention nurse will actually set up a visit with the patient's primary care physician the following day. And by the way, how reassuring for that patient in the emergency room to know that a nurse with our organization is sitting with them in the ER and actually has access to their chart and to their primary care physician and is communicating securely with the primary care physician. So those are some of the capabilities we've built in Columbus, and we're building in many of our 17 markets to really bubble wrap our high-risk patients. So Kevin, I think I'm passing off the next slides to you, and then we'll look forward to some questions.
Great. Thank you, Bill. One of the things that this global risk model has done for us in Austin, that as a physician leader in my community, I'm probably most proud of, is the reality. The leading groups in Austin, Texas, the independent leading groups, were either very limited or in many cases completely closed to new Medicare patients for access. The economics and the fee-for-service model dictated that the commercial patients were paid higher, and the physician offices had to balance how much Medicare they were able to take on. Today, in the global risk model, every single primary care physician at our independent groups, over 400 doctors in Austin, Texas, are wide open to Medicare and Medicare Advantage patients today. It's a completely different experience than our colleagues at the hospital, the ER physicians, the hospitalists, the folks working in skilled nursing facilities who are desperately trying to find great primary care for these patients with limited access, now have wide open access to what our market considers the best physicians in the market. So that's been a very different experience that this global risk model has really opened up for us. As a result of this, we've been able to not only have access where a patient can be seen within 2 weeks in our primary care offices, we've also been able to build. Bill highlighted many of the services they built in his market. We also have been able to expand our services as we reinvest in our practice through the agilon health model on preventive health. So our ability to close gaps in care, to go to the home, to fill pharmacy needs, to fill cost needs for patients has increased. And as Steve pointed out, our goal is to really expand access even more. So we've expanded more than 20 PCPs per year to continue to grow primary care access in our market. So while the statistics show that primary care is decreasing around the country and that we can't meet the demand of this growing Medicare aging population, in our market, we are meeting it. And we're actually growing PCPs at the same rate in order to bring these Medicare patients into our practice. And so all of these things really at the core, as we think about sustaining independent medicine, is this global risk model in a partnership with our partner, agilon Health, has enabled us to really unlock the things that you're seeing: access to primary care, better quality of care, and reducing the unnecessary costs that have been in the system in a model like this. So that's our story in Austin. And with that, I will pass it back to you, Steve.
Great. Thanks, Kevin. So we've tried to kind of quickly talk to you about how important independent primary care access is for over 65 Medicare beneficiaries. But here we show you some of the experience and outcomes that have derived from the partnerships that we've been talking about. We've been able to dramatically increase the amount of annual wellness visits from a 35% national average up to 78%. Greater than 90% of our senior patients talk about being satisfied or extremely satisfied with the access that they have to that physician with whom they have that relationship. Greater than 95% of patients are saying they're getting comprehensive, high-quality care from their provider. And perhaps most impressive are the Net Promoter Scores. 83% for patients and 73% for providers. Those are world-class, period, but in healthcare, they are really at the very top. And one of the amazing things is that in 2020, as crazy as it was with COVID, those net promoter scores actually went up. Senior patients said, I felt cared for. I had a relationship with someone. I knew where to go, and that relationship was maintained. Sometimes it was through telehealth because you weren't able to see someone in person. But that's the power of independent primary care and all of the programs that Bill and Kevin talked about. And as you have more primary care, look at the impacts on the right. 42% lower emergency utilization than the fee-for-service norms in these communities. 47% lower on the inpatient hospital side than the benchmarks. 26% lower on readmission. 90% of the members through our partners are in 4- and 5-star programs where the national average is 77%. In 90%, greater than 90% of our physician partners believe the quality of care programs that was developed as part of this agilon network and partnership has really allowed them to provide better care. So physicians are loving it and patients are loving it. Okay, well, a couple questions to kind of wrap this up and give people some context. Bill and Kevin, I am interested in kind of your decision process as you thought about the value-based care model and the decision to partner with Agilon Health. Could you talk with people about that journey in the process?
Yeah, thanks, Steve. As we were moving along in shared savings towards risk, we knew that we had to move into risk. We knew that in order for us to recognize the full value we were creating, we had to move to full risk. And to do that, even as one of the largest independent primary care groups in the country, we couldn't do that without a partner. And when I say partner, that's what we were looking for. We were not looking for someone to purchase us. We were not looking for someone to purchase part of us. We were looking for a partner and not a vendor. We didn't want a vendor relationship that might last 2 years or 3 years or have to be changed because of many different reasons. We wanted a partner, and we found that in Agilon. And we found it in Agilon because we could build this together. And quite frankly, that's one of the current attractive things about Agilon is we continue to build it. We continue to iterate on it. New groups come in with new ideas, and we bring those into the organization. So this product of Agilon continues to evolve based on the physicians that join the organization with ideas and with care management benefit from. So the most important thing to us was finding a true partner to move into risk.
Yeah, Steve, I would answer somewhat similarly. As a smaller group than Bill's group, we really felt like if we looked at the next 3-4 years of our organization, we were doing well. We were in an ACO program and creating savings. We were doing reasonably well in some of the commercial value-based space. Yet the pressures were real. The cost to hire primary care, the competition in the marketplace, the increased overhead. If I looked out 5 to 7 years, I really felt leveraged in the independent business model. So we really also needed a partner. We knew that being independent, that we were practicing based on the statistics that we all see, that we were practicing better medicine from a quality and cost standpoint, and we really wanted to remain independent. And so we looked for a solution, and most of the other solutions as we looked out there were either, as Bill said, vendors or they were looking to purchase us. So this was a unique model that allowed us to sustain our independence and yet participate in a model that's giving way better care and is helping the physicians win. So instead of me looking out 5 to 7 years and feeling leveraged, I look out 5 to 7 years and I'm pretty excited.
That's fantastic. Well, I think we've got time for one more question. And I'm really interested in some of the examples of how you're working with specialists differently and hospitals differently as you've moved into value-based care, kind of some of the transformative ways in the community that those interactions are occurring. So, Kevin, you want to go first?
Sure. I mean, the model has really allowed us to, in essence, we are responsible for the healthcare dollar. And we're also responsible for the primary care of our patients and hence the downstream referrals that we pointed out earlier. So we've gone to many of our specialist colleagues and work with them in helping them understand our model. Of course, they love to take care of our patients. They love excellent referrals that are appropriate and needed to be cared for. They don't really enjoy referrals that are unnecessary. And so we've really partnered with them in a way to identify what is a necessary referral, what is high value care within your specialty, what is low value care. And we've been able to really partner with select specialists who want to work with us in this way. They consider us sort of the thought leader in the market around where this is headed. You know, in many ways, they're trying to learn what is value-based care within my specific specialty. And so we've seen that partnering together. We've had rare instances where physicians aren't willing to entertain that. And frankly, we choose to give our business to the ones that are. That's kind of been our experience.
Bill, you get the last word.
Thanks, Steve. I think I would just say that being an independent primary care physician allows me to refer my patient, Betty Smith, to the appropriate specialist in our community. I don't have to refer within a given network other than payer network, but I do not have to refer upstairs all the time. And as a primary care physician, as I sit in front of Betty Smith, I want what's best for Betty Smith. So a broader selection of specialty services serves not only the patient, but serves me. And fortunately, we have data that can guide us as to what's best for Betty Smith and where value lies in the community. And it's an opportunity that many physicians don't have, but being independent allows us that ability.
Great. Well, we'll leave it there. Thanks, Bill. Thanks, Kevin. Hopefully, we've convinced you that more independent primary care leads to better care for seniors and communities need it. So thanks, everyone. Hope you have a great afternoon.
Thank you.
Thank you.